for inviting me to share with you this evening. It's indeed a pleasure always to talk about the health of mothers and, of course, the newborns and thereafter the children. So colleagues, I'm delighted this evening on a Good Friday and on the World Health Day to once again be submitting something on improving really safe motherhood in our country. I'm sure you know that we have lagged behind in regard to maternal and newborn health. Definitely, as a country, right now, we have been placed at 284 per 100,000 live births. But as you know, the SDG is asking us to drop down to 70. The official figure, which is being quoted, still remains the 2016 Uganda Demographic Health Survey, but the 284 is from the UN current status of maternal mortality globally. You also know that we're still not doing well with the newborn deaths, and we're at around 23 per 1,000. If you see the targets for 2030, and if you look at, this is 2023, we have only about 6 years to go. We must double our efforts to make sure that we end these preventable deaths of newborns, of under fives, of mothers. And if this is going to happen, we need to ensure that everybody, universally, we are reaching out to mothers and newborns with quality health care. Uganda has committed to end this maternal mortality and newborn mortality. And all of you know that we do have very good policy guidelines to facilitate us to implement evidence-based actions. You all know that currently our sharpened plan requests us to really focus geographically and make sure that we are committing and making action plans in our districts. Busoga, thank you for the energies now you have almost every week to be discussing what are the issues confronting us in the region. As you are implementing safe motherhood programs, we are expected to focus on the very high burden populations. We need to scale up our services. We need to make sure that those very difficult people to reach are being reached. And we must scale up our high impact solutions, which I hope we know, as we are going to show you the pillars of motherhood majorly are 4, and we are going to show you the broad areas later on. But it is going to be important for you to appreciate what the high impact solutions are in each of these pillars, and you implement them universally in the Busoga region. We are also now sure that if we are going to dent maternal and newborn mortality and morbidity in this country, we need to educate, we need to empower people. Of course, we are focusing on girls and women, but as you later know, these girls and women are also in families which have men, so the economy, the environment matters a lot. I am glad Busoga Forum, I think, discusses beyond health as health, because if we do not discuss and improve our economy and environment, it is also difficult. And we must be mutually accountable and make sure that everybody is implementing what they are expected to implement, including our political leaders in the region. I don't want to repeat this because I've said that we have new figures which tell us that we have made some progress. And this is important for us to know that we are making progress. I think when you don't see yourself going down, sometimes you lose heart. But it is important for us as Ugandans to appreciate that all these efforts we are all putting together are slowly leading to a reduction in maternal mortality, but we need to double our efforts. Making motherhood safe for the world's women calls for national governments, multilaterals, bilaterals, NGOs, civil society, and all of us to be working together to ensure that we have the necessary political and financial support we need. This is because, indeed, saving mothers is cost-effective, as we know. You know how important women are in the lives of families, but also as labor force contributors. And of course, women are a major input in the total community well-being and therefore production and productivity on which the country is going to depend to go forward. But we also want to remind you that for women of reproductive age, pregnancy and childbirth are the leading causes of death and disability. And this accounts for 18% of the global burden of disease in this age group. So it's important, as we all continue to do something important, for us to inform our communities that although pregnancy is perceived to be a normal event, it is important to understand that every pregnancy carries a risk. I think we need to deliver this message correctly in our local languages. I think we are not communicating enough for people to understand that every pregnancy is a risk, and it can actually lead to a maternal death or a newborn death. It is important for us to appreciate that our progress in making a difference in the preventable deaths of women and newborns has not been very smooth for us. Our annual rate of reduction has been slow, as you can see. These are RMNC trends, and we don't have the most recent. We probably will have another UDHS results soon. But the data, the official data, the Ugandan official data is as you see, and it stops at 2016. The important thing here to note is that we have a very high fertility rate, and definitely this poses a risk to every woman because it is only women who are pregnant who die of maternal death. At the same time, you see that our contraceptive prevalence rate is low, is really low. So if we are going to expose ourselves to pregnancies more frequently, we are going to have more risky pregnancies. And that is why we still, one of the reasons why we still have high mortality is that mothers are frequently exposed to pregnancies. You can see that the neonatal mortality has also not done well. And as you heard from the recent Joint Review Mission for Health, you will understand that actually one of the stagnant figures is those of the newborn deaths. And we need to do something about it. We all know and we are sure that our mothers, most of the mothers dying in our health facilities is because of hemorrhage, it's because of hypertension, it's because of sepsis. And we need to really up our game on this, on the quality of care we are giving our mothers. And we must ensure that we work with communities to reduce the chances of being obstructed either in communities or in our own health facilities. So we really must ensure that in Busoga region, as we move on, we are constantly checking ourselves. Why should really a woman die? Because when we have facilities to prevent hemorrhage, we have facilities to treat hemorrhage, we have facilities to prevent sepsis and also treat sepsis. So for each of us in our own health facilities where we are seated, in our own communities, we must make sure that our work plans in the region define who is going to do what and how they're going to do it and with what resources. We are doing a lot as health workers, as people of goodwill, but one of the things which we are not doing well is really to estimate the inputs we need in order to provide a quality service. And I think we need to do this better. Our newborns continue to die, majorly of asphyxia, preterm, and of course sepsis, as you see, even here in Uganda. And obstructed labor is a reality in our districts. Women can't move easily to our health facilities. And sometimes even when they move to our health facilities, our health services are not timely. And that's a huge problem. Our skills to resuscitate these babies when they are asphyxiated, we need to up them. I'm glad that there are many civil society organizations here. They are also partners supporting Busoga, a number of you really. And I think you can dent these mortalities and morbidities if we work better together. Ideally, we are supposed to move forward on establishing kangaroo mother care facilities in all our health facilities, and we move down now to the communities to ensure that families have a good idea of what KMC is. And KMC is not only good for the preterms, but you know that it's also good for the term babies. But very important now to strengthen all our health facilities as much as possible, to teach communities what KMC is, to teach and ensure that all the midwives and doctors are able to provide KMC to those preem babies. I talked earlier about the pillars of safe motherhood. We must up our game on family planning. We must reduce the unmet need. We must improve the quality of care of family planning. You know now that Antenatal Care also, there are new guidelines from the Ministry of Health. The third pillar is also ensuring that we have a clean, safe delivery. We have good newborn care and postnatal care. And definitely we all know that emergency obstetric care is a huge pillar in ensuring safety of mothers. When they develop complications, there must be life-saving care and it must be available in time. But underlying all this is really the need for us to make sure that in our communities, people have some basic maternity care. There is good hygiene, there is good sanitation, there is good nutrition. And above all, women are treated as valuable and they need to be healthy and we accord them their rights. Health services is one of the basic women rights, basic human right, and we must ensure as service providers, health workers, NGOs who wish not to see mothers die, women's status must be improved in our localities. We must ensure that services are available for all those pillars I've mentioned above, and that you are involving, you are engaging the community leaders. We need a reasonable amount of resources to dent the maternal health complications, and we must improve broadly the services we offer to women. But women must acquire a higher status than they are currently having. I will not go in a lot of detail about family planning. For us who are probably on this forum, it is obvious for us, but it is important for you to appreciate that when you're talking about family planning, you need to explain exactly the benefits for the mother, for the child, what it is, what are the benefits for the men, short and long term, what are the benefits for the community, short and long term. People must understand that the current situation which we have on the roads, the fact that we've cut all the trees for charcoal, the fact that children are not fitting in classes even at university level is because Uganda is not able to control the fertility levels we have, and yet we have facilities which could have helped us to do so. So I'm glad that partners are here, and you need to ensure that we are guaranteeing communities with good family planning, quality family planning. We must enhance political support and community support for family planning. And above all, now you must ensure that there is proper logistics for it, that the services are actually available, communities are available, and the service providers who are skilled are available. Antenatal care, you know very well now that we've moved to the 8 contacts, and every contact is purposed to do something. If we can have enough input in the quality of antenatal care we are giving to our mothers, we should be able to detect a number of risks, address them in time, prevent that which may occur if we can have quality antenatal care. And this is a challenge to most of our health facilities where we know that some of the inputs are not enough. Are you aware that these are what we have put down as the package, which we need to ensure that the women are accessing? You are able to do simple things like all women accessing iron and folic acid. You are able to do blood pressure measuring. You are able to know the HB. They are being tested for syphilis, HIV, hepatitis. You are doing birth emergency preparedness plans together with their male spouses. And of course, nutrition is so important. We are also saying this. Pillar number 3, for us to sustain mothers alive and well, is ensuring that they're delivering under skilled attendants. Those are the midwives, the doctors, the nurses who have been trained in midwifery. I know that we have a problem in Busoga. I know that we have a number of deliveries in the communities, but you must begin now to really engage the communities and support them to reach services in time. As health workers now, we are supposed to encourage birth companions, people who can accompany women to be with them in labor, so that they can also support us, since our numbers as midwives, as health workers are not so many. There is something that we can teach the birth companions, the husbands, the mothers, to these people who are in labor, so that they can also contribute to the care we give. In order for us to give this care, we need also a number of inputs. As you know, we need delivery kits, we need to supplies, we need to cancel, we need medicines to relieve pain, we need oxytocin. Are we sure that our health facilities are well stocked with what we need to do our work well? Because if we don't ensure this, women will come and they'll be missing the evidence-based practices that we need to give them if we don't have adequate inputs. we are now requesting that the 666 rule, the 6 days, 6 weeks, 6 months is observed for postnatal care. And that we really ensure that this very critical moment in the lives of women and children is really observed by a skilled health attendant and is able to address, if there are any danger signs, is able to address the needs of both the mother and the newborn, because we know that the majority of newborns actually die in these first days of the week when they are born. 70% really, we lose them in the first week. And yet the care within the first week is really minimal in most of our health facilities. The 6 hours, the 6 days, the 6 weeks, the 6 months must receive the packages that the Minister of Health has described for us. We have guidelines to support us to do this. And we need to care. We need to inform our communities about the danger signs, what to expect, what to do when they're there. We need to counsel mothers. We need to immunize. Don't let children out of your health facilities before getting their first doses. We must be careful with the maternal well-being of, because if it's not looked after, then don't expect proper breastfeeding. We are still advocating for responsible fatherhood, where every man who has a spouse who has delivered begins really to make sure that he is available for this very critical time in the lives of both the mother and the baby. We have understood that the signal functions for emergency obstetric care must be observed in both health center 3, 4, and of course the hospital. But it is now critical that you keep checking on the health facilities you're supporting and the skills. Are the health workers able? Do they have antibiotics, parent oxytocin? Do they have magnesium sulfate? Can they remove products of conception which are left behind as in incomplete abortion? Are we all proficient? Are we able to do cesarean section when the need arises? And do it really within 30 to 1 hour's time when you take a decision, so that you reduce this delay in our health facilities. We know that we have major challenges in achieving this, but we must work towards improving the quality of care for cesarean section. We must work towards good post-operative care. We must ensure that women and their spouses can afford cesarean section in our health facilities. You know, up there we talked about vulnerable communities. I think Busoga has a number of vulnerable populations which probably can't afford a lot of costs related to emergency obstetric care when the need arises. Overall, we know that men and women don't have adequate information on the danger signs when they arise. Women and men stay at home when bleeding starts. Women and men are poor. There's poverty. In the region, there's poverty in the country for men and women. Poor education level, which influences what you do. Poor health-seeking behavior. Even when bleeding started at 8, women will arrive at 8 p.m. in the night. And I've already talked about high fertility. But we know that we need now to encourage the husbands, the spouses of these women to be available for support. For us, we are challenged with our low quality of services, which we are providing, but we must take action to change the current quality of care so that it can be meaningful to the women and their newborns, and of course, their families. So it is important, because if families lose their contributions to the household management, you know that the children and the family members really suffer a lot. But also as communities, they've lost a productive person, they've lost a vital member of the family, and life for surviving children is 10 times more likely to have problems within the 2 years after the mother died. So there's a lot we can do. Even in low resource settings, Uganda, we know that we have low cost interventions that can save mothers and newborns, but we must invest correctly in health. Colleagues who are in this forum, you need to do a lot of advocacy for our various levels of governance to understand what kind of investments they can do to save mothers. Because each of us has a role as religious leaders, as cultural leaders, as community leaders. If we can mobilize and know what we can do. Leaders, for instance, in the community can ensure that there's emergency transport when women need to go to health facilities, and make it available and make sure that the communities they are ruling, governing, would contribute, because government may never be able to completely contribute. But we see a lot of innovations in your region. Your political leaders are coming in to support wherever they can. But maybe some of the things they can't completely do. Maybe fuel is not there. What system have you put in place to engage and empower communities, women and men, to participate and also be accountable? This is a big question for us because we also know that we are dealing with the high level of poverty. But even within the poverty levels, how are you engaging and communicating to these various vulnerable groups so that they appreciate what needs to be done? We need a strong and sustained government commitment. We need more partnerships. Please mobilize everybody you have. Mobilize Rotary. Mobilize the NGOs you have, maltrators. Mobilize banks so that they can support, for instance, water harvesting. There are a number of our health facilities without adequate water, without even gutters to harvest and put in a tank. Those are things that can be done by various NGOs, various institutions, if we come together. I know you have different vulnerable groups, disadvantaged women and men in islands, in slums, in urbans, but they are poor urban communities, and of course in very distant rural areas. But how do you mobilize them? How do you strengthen their capacities? How do you work with private bodies? How are you encouraging providers to provide low-cost interventions? We've heard about women and men coming in institutions and they can't pay $3,000 for a cesarean section. It is still indeed our region, Busoga, and Uganda as a whole, with adolescent pregnancy. Adolescent pregnancy is a pandemic. I think it is an epidemic in the country, and we must really reduce, we must say no, zero tolerance to adolescent pregnancy, because it has a various, very negative implications on that child who has become pregnant, dropping out of school, probably with STIs like HIV, and really the lack of skills at that time. If she drops out and having just been in S1 to 3, what can she do thereafter? She's going to propagate poverty. She's going to propagate ill health. So as a region, I would also advocate to you and advocate to the rest of the country also to make sure that we are engaging communities, we are engaging boys and girls. We are engaging offenders who really abuse these children. and they become pregnant. We must do all that we can, because you all know who are here, that there are multiple vulnerabilities which lead us to where we are. A very high prevalence of teenage pregnancy in the region. And you know that there is something that we need to do about it. Coming away from adolescent pregnancy, which is a reality, we want to talk about the many couples, the many men and women who have unwanted pregnancy, and therefore high-risk unsafe abortion as an issue. We must be able to make women prevent unwanted pregnancies. We must make sure that the services that we need for these women are available, and we must skill our health workers. We must equip them. I shouldn't close without talking about violence in homes, because there is evidence now that we are also one of the countries with very, very high physical and sexual violence. You know that about 27% of women have experienced intimate partner violence within the 12 months when the UDHS was conducted. There are so many testimonies of women telling us what has happened to them as they are pregnant. You know that violence is highest, is very high for pregnant women. And this really must be addressed, because we have data coming in from the health facilities showing us that when intimate partner violence happens, about 3.7 times of these women are likely to have low birth weight. And in another study we have in Uganda, 16% of women reported experiencing physical violence during pregnancy. And this is shown in 2012. But Kaye also has told us that women who had experienced intimate partner violence during pregnancy were 1.4 times more likely to develop obstetric complications like hypertension, premature rupture of membranes, anemia. You can use this information really to educate men about the need to stop violence in homes. We also know that infants of mothers who had ever experienced intimate partner violence are 2 times more likely to experience even illnesses like diarrhea. And this was by Karamaji in 2007. So there's data to help us educate and advocate to communities to stop some of these very dangerous practices that are in our communities. We can educate them, we can have partnerships with them, and we can really change many things if we work more closely with communities to address these issues. But we must get down to where the communities are. Speak in their language. Let them ask us the questions they want to ask us. Please explain to them, because for you, you have the scientific knowledge. And if the science can be translated into local language, I think it will make a lot of difference. Let us not keep in the health facilities, up in the NGO speaking to ourselves. We need to engage. You need to make sure that husbands are selecting birth locations, are identifying where their wives are going to deliver, are caring for the mothers, and they are really with them. If we do not do adequate birth and emergency preparedness with couples, we are having many mothers fearing to come because they are not adequately prepared. We must make sure that there's transport arranged at the community level, that communities take responsibility when the need arises. For us, other areas of need relate to water and sanitation, food and nutrition, shelter in the facilities where we are, because some women are asked to stay around for days, but really some of the health facilities have very insufficient shelter. We need to appreciate that we must provide long-term and predictable funding to many of these interventions which we have mentioned. And in the long run, we need to take a full health systems approach. If we don't look at the finances, if we don't look at the infrastructure, the health worker needs, availability of medicines, being able to provide adequate data and influence the decision makers and develop good plans for the issues confronting us, it is going to be difficult for us to achieve the safety of mothers and newborns. We have talked about these delays over and over and over with many of you. We all must know, we must address the home where our women and men are. You must be able to speak to them and tell them what these delays are and how they can avoid them. Please spend a lot of time at the community level and empower it and give it knowledge and educate it. But you're also confronted now with the transport arm. Many of our mothers are coming in from very rural areas, far away, in islands. Worst of all is the third delay in receiving care in our health facilities. And this must be really, I think it is for me the closing and most hurting delay. If men and women overcome the first and second delay and they really can't get our services in time, I believe this is the worst that can happen to us. And we need to work very hard to address the quality of care which we are giving to our mothers and their families so that they can gain confidence in us. They can always come back when they know that if they come to us, they will have healthy newborns. They'll also go back healthy. This is the challenge we have, but it's not insurmountable. And I would hope that we are going to concentrate on improving our services as we go out to invite them to come in, because if you're inviting in visitors, you must make sure that the quality of care you are giving is good. Fortunately or unfortunately for the safety of mothers, you must do the three concurrently. But with limited resources now, sometimes you have to make choices, but they are difficult choices. I'd like to thank you, Busoga Health Forum, for giving me this opportunity once again to speak about safe motherhood and how we can achieve it together. I thank you for the opportunity. Colleagues, I hope you have been hearing me.
Yes, Dr. Olive, we have been very attentive.
Thank you very much. That's the end of my
session. Thank you very much for this beautiful presentation. Thank you for unpacking for us this topic, interventions for safe motherhood. I think as Busoga sub-region, we do have our challenges, And from this presentation, definitely we see areas where we can adequately support the region. On the call, we have technical teams and also teams that are not technical. So but we do appreciate the mix.